Welcome everybody to the first grand round for this year. Today it's global surgery, and I'm very pleased to introduce two speakers on topics that are exciting. So Professor Chris Lavy will be speaking on the strengthening of district general hospitals in Africa, and also setting up hospitals in Zimbabwe and beyond. Our second speaker is Mrs. Grace Drury, and she's going to be talking about developing and training for treating walking age children with delayed presentations of clubfoot in Ethiopia. So just an introduction to Professor Lavy. Many of us know him really well, but many of you may not know that his career started in anthropology before he trained as a GP and then took on orthopaedics, where he worked as a consultant in London. Following that, he moved to Malawi and became the professor of orthopedics and set up the first orthopedic hospital in Malawi, followed by one in Zambia in 2006, and a further one recently during the pandemic in Zimbabwe. He has a great passion for training in surgery and on a global level, and he's a founding member of the College of Surgeons of East, Central, and Southern Africa, and was also one of the team members for the Lancet Commission. Has been very active in the Global Surgery Group, and has co-led the Oxford University Global Surgery Group. Mrs. Grace Drury has been working with Chris for many, many years. She's a program manager and researcher in the Nuffield Department of Orthopaedics, and she's worked on many projects in sub-Saharan Africa, linking clubfoot training, district hospital, surgical systems research, and participatory action research. Her basic degree background in education is in English. She's got a degree in English from Oxford University, and her background is in education and international development. She also has a degree from the Oxford Brook University on international health. So we are going to start off with Mrs. Grace Drury's talk. So Grace, please.
Thank you. Thank you very much. Chris, was anything you wanted to say initially?
Yes, thanks very much, Kokila. So Grace is going to give the first of the four little talks, but I was going to give a little bit of background to our Oxford University Global Surgery Group, which has been running for several years now. And you may have thought because of COVID we weren't very active. On the contrary, the projects are all continuing. And what we're going to do today is just give you a little canter through some of the projects that the Global Surgical Group has been involved with of an orthopaedic, well, mainly an orthopaedic nature. And I have to say at the beginning a few words about the orthopaedic, about the Oxford Global Surgical Group, and about surgery in the world as a whole. Now, if you want to understand surgery in the world, the key thing is to read the Lancet Commission report published 6 years ago. However, if you haven't got time to read that, the many pages of that report, just remember the figure 100. And if you think that the NHS has got problems, there are many countries where the problems are 100-fold. We think we haven't got enough surgeons and anaesthetists. There are places in the world which have 100 times less. We think we're not training enough. There are places that are training 100 times less. There are places where you're 100 times less likely to get an operation than you are in the UK. And it's working to the Oxford University Global Surgical Group works with colleagues all around the world to address that inequity. So what we're going to do today is just canter through with an overview of 4 projects, one on training for clubfoot, one on systems research and improvement, strengthening district hospitals in Africa, one on improving facilities and working with the Ministry of Health in Zimbabwe to build a new hospital, and then lastly, Grace is going to give you a little overview of the global group, and we should have time for questions at the end. So let's go. Grace.
Great, thank you very much, Chris and Kekila. So the first project to introduce you to is how we've developed a series of training materials for clubfoot, particularly focusing on building capacity of trainers in sub-Saharan Africa. And this started in 2015 with a grant from the UK Department for International Development to develop 3 related courses in clubfoot training. Clubfoot's a common congenital condition, but the majority of cases are seen in low and middle income countries. If it's untreated, then it can become quite a painful and disabling deformity, as you can see in the upper picture, where the child can't walk normally and is having to, he's not able to wear shoes normally. It can be corrected quite straightforwardly if it's treated early through the Ponseti technique, which is now recognised as the gold standard. And that usually involves gentle manipulation of the foot, week by week, using serial plaster casting to achieve as much correction as possible. Most babies would then need a tenotomy to release the Achilles tendon to achieve further correction, and then a period of time wearing some foot abduction braces to maintain that correction and to avoid relapse. So we developed the first course was a basic course on this technique, the Ponseti technique, to treat infants. And then we developed an advanced course for the more complex cases as well. And so that's for the first 2 courses, which we developed with help from colleagues from the UK Clubfoot Consensus Group and also across 18 countries in sub-Saharan Africa. And that built on materials that already existed, but were sort of very different, and none were sort of recognised as the standardised version, which was sort of commonly used. So the 2 courses we deliberately made much more practice-based and to allow lots of hands-on engagement from the participants. So you can see in the first picture using clubfoot models to be able to show and understand the anatomy and how to correct the deformity step by step. We piloted the courses in Ethiopia and Rwanda in English and French, and these were settings where it was also possible to have patients as part of the training so that the participants could practice casting and foot abduction bracing, and to discuss how to support parents as well, as they're a key part of the treatment success. So we refined the materials through these different pilot courses to try and produce materials that showed how to organise a course of many practical elements all together. The third course that we then developed to supplement this was to adapt the training courses that we typically see in the UK medical education setting, but to tailor it specifically to how to teach a very practical skill like the Ponseti technique, which is really hands-on and tactile, to be able to successfully teach that through these 2-day courses, to be followed up with clinic support as well. And that was in response to a request to develop more regional training capacity, so that rollout of training wasn't dependent on just when international visitors could come.
That's the warning given to the English and Wales.
So we wanted to make sure that the course was in response to what health workers were really asking for. So we started off with surveys and interviews on what the training needs were, and wanted to make sure that the materials are accessible, that people are credible and quality assured, with support for both trainers and trainees. And in developing that regional training capacity, we focused on 4 areas, which were the principles of adult learning, how to develop skills, not just in training on the course days, but how to mentor new providers and how to supervise clinics as well, how to organise these courses, but also to think about actually, is the quality of care in clinics actually improving, and how do we measure that? We looked at how to standardise the courses so that actually with a beginner's course, we're teaching the same way, rather than depending on each of the quirks or slight preferences of each trainer who turns up. So that meant we went through a careful consensus process to think about how, with beginners especially, how can we standardise this? And then through the advanced courses, people are going to sort of be introduced more to variations or different techniques as well. We looked at how to make the course as hands-on as possible to make sure we're selecting the right people for each course to get the best outcomes, which were the optimum ratios of patients and trainers and trainees, so people get hands-on practice, and to promote actually that there's a real role for multidisciplinary communication and working, particularly in many of the low resource settings where it's perhaps a different mix of cadres who would be providing clubfoot care. Also looking at if there is opportunity to involve patients, how do you do that well and considerately, and how can we promote interactive teaching as well. This is one of our favourite pages from the manual, which just includes the names of all of our many colleagues internationally and through the region who helped us to develop the course. And that was one of the real joys of being part of it. So since we finished those 3 courses in 2017, we've run those courses in over 28 countries. I think it's probably more than 60 courses by now. And then through further funding from Miracle Feet, STEPS Worldwide, and through the university's Oxreach crowdfunding, we were able to translate the manuals further. And you can see an example of Mongoli just there, which is our most recent project. The courses have also been used for training here in the UK as well, as they've been recognised. Actually, they're just as good for training health workers here. So although the course was originally designed to support healthcare workers in Africa, they've now been accredited as a level 1 and level 2 course by the Royal College of Surgeons in England. And that's led us on to our current project, which has taken one particular module of treating older children from the advanced course, and we've expanded that into a 1-day course. That's through funding from J&J Tropical Health Education Trust, along with many of the partners who were part of the first project. And so that 1-day course specifically focuses on what are the options for helping these older children who, for whatever reason, weren't treated for their clubfoot as infants. So we started off with a survey of practitioners because there's a limited evidence base really, or a growing evidence base on how to treat these older children. And so we wanted to see actually how what's the practice at the moment, and to draw on experience of those who are engaged with this. So we found out about what sorts of assessments are being used for these children, how they define successful casting in this older age group, what they might do when it's difficult to achieve sufficient dorsiflexion, what the surgical options and indications might be, what are the role of orthotics, if any, how they might manage recurrence, which rehab exercises would be most useful and why, and how they work as a team for these services for older kids. And this led us to refine the 1-day course to focus on these core areas: assessment, step-by-step correction, casting, surgery, rehab, team communication and family-centred care, when to stop and rethink, and thinking about the system as a whole, setting up services. In particular, the course introduces a clinical scoring system called the PAVA score, which looks at 5 different elements of the deformity in an older child, and also takes into consideration the age of the child, and that's to help predict how these children might respond to principles of Ponseti casting, although they'll still need some level of surgery as well. It's possible to achieve some good correction with the casting, and this scoring helps to predict which feet might respond most for that. So the project outputs have been to produce, again, supporting manuals for faculty and participants, the interactive teaching slides, but also, amazingly, a library of 20 teaching videos, most of which have been shot on site at Ethiopia Children's Hospital, particularly to show the surgical options as well, because that's something which we can't do in a 1-day course. Through this current project has been run pretty much through the pandemic. So there have been challenges which I think are familiar to us all in terms of the limited travel, the impact of the pandemic on clinical services and different team members who've been ill or self-isolated, and just general uncertainty about what we've been able to plan. So we've had to try and think of ways to overcome that through working with our colleagues and our funders to adapt the timelines for flexibility, think about contingency. We were already working a bit online, but actually using more tools and opportunities to achieve as much as possible through different ways of surveys or conferencing and collaboration. We weren't able to hold our pilot course as planned with the support of international trainers in person, but we, at that particular time in September 2021, the participants in Ethiopia were able to travel to Addis Ababa, and the course was delivered mostly by the local faculty there, with some support remotely online from our international colleagues as well. Of course, we're not the only one who've had to adapt to delivering training online, so our colleagues in Global Clubfoot Initiative have helped us a lot with the way that they've shared their lessons learned as well. And we recognise that it's actually shifted the balance in the project of the ownership to our local colleagues, as we've needed to rely on them more to deliver a lot of the planned activities or project outputs. And ultimately, I think we all think that's been quite a good thing in terms of project sustainability and and to support rollout in the future as well. So our pilot course, we ran it twice in Addis Ababa in September, was on Zoom. For local participants, followed social distancing guidelines at the time. Colleagues joined online and did things like narrating over presentations and videos as well. But we're really to support the local faculty who were the main drivers of the course. And they were able to have patients there so that the participants could practice scoring and assessment of the feet and plaster casting as well. And there are some mentorship activities planned to follow up this. Some have been postponed just because of the limitations of travel domestically in Ethiopia at the moment, but they should be able to go ahead this spring. So this one-day course is very, very nearly finished. We're translating it into Amharic at the moment. And so within a few months, we'll be able to share that with partners through the Global Clubfoot initiatives. There'll be these 4 connected courses to support clubfoot treatment. And I'd like to hand over to Chris for the next project. You're just on mute.
Thank you, Grace. I think I'm off mute now, and whoops, and there we are. Have I got control now? No, I haven't. There we are. Great. I think I've got control. Have I got Surge Africa slides showing? Wonderful. Yeah. Well, for the younger members of the audience, we used to be in Europe, in the European Union, and we are drawing to the end of a very big project that was funded by the European Union, which we ran in conjunction with European partners in Amsterdam, Radboud University, the Royal College of Surgeons of Ireland, and four groups in sub-Saharan Africa, the University of Malawi, the Association of Surgeons in Zambia, the Association of Surgeons in Tanzania, and College of Surgeons of East Central and Southern Africa. And this is a project looking at improving surgery in district hospitals. Now, when you mention the word district hospitals in the UK, we think of a place down the road from Oxford, which has probably got 10 orthopaedic surgeons, 10 general surgeons, 30 anaesthetists, and that's a district hospital in the UK. In sub-Saharan Africa, certainly in Malawi, Zambia and Tanzania, a district hospital will usually have a doctor who deals with the admin, and the surgery will be done by paramedic, orthopaedic clinical officers, general clinical officers. None of the hospitals that we were dealing with had an anaesthetist as a medically trained anaesthetist, but the anaesthetics were given by nurses with a bit of extra training, or paramedics who would do a course in anaesthesia. And as I said at the very beginning of this morning's talks, there's a massive disparity in the surgery that's done. The World Health Organization has a group of operations called the Emergency and Essential Procedures. And in the UK, 95% of people who need an emergency and essential procedure operation get it. In sub-Saharan Africa, 2.5% get these. and where the people live are where the district hospitals are. And so it's really crucial thing to reduce disparity in surgery to improve district hospitals. And the surgeons aren't at the district hospitals. Surgeons and anaesthetists as a whole love to live in big cities, and you'll find the surgeons in the big cities in sub-Saharan Africa and the anaesthetists, but not in the district hospitals. So how do we improve services in the district hospitals? Well, what this enormous study, which is drawing to a close, was looking at was whether you could improve services, and particularly the amount of surgery that's delivered in district hospitals, by regular visits by specialists and mentorship of the staff that are there. And these are the three countries we chose, Tanzania, Malawi and Zambia. And it was a big project looking at trying to increase the numbers of surgery that were done, but also we did a lot of economic analysis. And the intervention that we were using, that we were studying, was regular supervisory visits, in-service training and mentoring support. And we were delivering this intervention to 31 district hospitals, pretty much 10 in each of the three countries, 11 in one of them, obviously. And then we had 34 control hospitals where the mentoring and support and visiting intervention wasn't happening. So we could compare these at the end. And if you're expecting the final results of this study, I have to disappoint you because they're not quite out yet, but I'm telling you a little bit about how we did the study. Who was going to be intervened upon and supported? Well, the surgically active clinicians in the hospitals, the surgically active anaesthetists and the relevant nurses in the preoperative, perioperative and theatre teams. And the training was delivered by specialists from the linked referral hospitals. And the duration of the intervention was a couple of years. We devised the protocol for the study and published it. And in particular, we used, is that slide coming up properly? Oh, good. Okay, in my screen, it's split into two. We used a concept that I hadn't used before, participatory action research, PAR, where you involve the subjects of the research in the planning and delivery of the research. So we make our research plan, we make our protocol, and we start it off. We then see how it's going, we observe how it's going, we discuss with those involved in it, we reflect and we make changes. And we did that at the very beginning of the research, we did it in the middle of the research, and we did it again at the end. So we had a baseline PAR visit to all the hospitals at the beginning and at the middle and at the end. At the beginning, back in 2017, we invited representatives of all the district level hospitals that were going to be involved in the study, and you'll see 67 or slightly more came in at the beginning, and some of them dropped out. But we had representatives from all of those hospitals, the surgical team, the anaesthetic teams, theatre nurses, those who were involved in obstetrics, and the hospital managers, and of course members of the Ministry of Health. And we had semi-structured group discussions, and we sat with the people in the district hospital and said, so what is it about your hospitals that you'd like to improve? And there's one of our PAR meetings. The PAR meetings helped us to identify the particular training needs that those working in the district hospitals felt they needed. Preoperative and perioperative essential surgical skills, treatment of common conditions, the management of equipment, anesthesia, infection control. They were desperate for mentoring, and then feedback on referrals. When they did have complicated cases and they sent them off to the central hospitals, they wanted to know what happened. And we used the baseline PAR meeting for priority setting and action planning in devising the research intervention. And we made site-specific visit plans for each of the 31 hospitals where we did intervention. And the PAR helped us, as you can see here, to actually negotiate the plan, the length and frequencies of the visits, the scopes of the visits, the nature of the team that we brought along. And the teams, we gave them the option of having a visiting obstetrician, gynecologist, orthopaedic and trauma surgeon, general surgeon, anaesthetist, and theatre nurse specialist. We had midline PAR meetings where we reviewed the progress, what was going well, what was going badly, logistics, and what could be improved. And then we had PAR end meetings at the end of the intervention to again to look at how it had been, with presentations from each of the teams where the hospitals where there'd been an intervention. And in particular, we focused on the quite interesting methodology, the most significant change, where you look at as individuals, you look at what has been the biggest difference. It then brought up this whole project brought up the big question of what procedures should be done at district hospitals in sub-Saharan Africa, and that actually spawned a whole other research direction, which is continuing. Well, findings in terms of mentorship, what went well. People reported much better increased teamwork, mutual respect between central and district hospitals, better transfer of skills and knowledge and confidence buildings. What were the challenge? Well, one of the difficulties was that the mentees, the staff in the district hospitals, often changed. It was remarkable how often you get a complete change of staff. There were issues of attitude. There were issues of visit postponements when they were all ready for a visit, and then sometimes poor communications about the visits, so that the hospitals weren't ready for them. What went well with communication? Well, improved quality. In particular, in all the countries, the use of a WhatsApp group, a carefully monitored WhatsApp group to give information about patients, and in particular referrals. Challenges, well, there was continued lack of feedback or reduced feedback about referrals. Poor documentation and often poor communications on the visit logistics. The unintended or negative consequences of the visits were that some of the poorer hospitals, when you brought a bunch of specialists to do some teaching and surgery, you would deplete the surgical and medical supplies, and getting supplies is extremely difficult. We did find some of the mentees who, with a little bit of training, got overconfident and took on rather bigger things than they should have done. The mentees themselves did complain about the unavailability of incentives. You want us to do more work? Where's the incentive? Where's the financial incentive? Burnout, in places where there were very few staff, and patient overload. Patients are clever around the world, and when they know there's a visiting team coming from the specialist hospital, they can crowd the district hospitals. And then, of course, the increased costs of regularly increasing the amount of work that you do in a district hospital. Findings, and these are quotations that our staff gave on surgical care: increased volumes everywhere, increased use of checklists, swab counts, and surgical reports and surgical registers, reduced post-op infection. I love this quote. The impact has been overwhelming. A number of people are able to access affordable surgery closer to them than referrals to central hospital. Research findings. If you go to our website, you'll be able to see links to all of the papers that I'm just going to touch on. We did a scoping review of what surgery was being done in district hospitals. We did a big review actually at one of the conferences, the College of Surgeons of East Central and Southern Africa conferences, where hundreds of surgeons from sub-Saharan Africa come on, and we did a review of their opinions in the region. What actually should happen at a district hospital? What's an appropriate level of surgery to have at a district hospital? We reported on the anaesthesia capacity in district hospitals, and we evaluated the managed surgical consultation network. For that, read WhatsApp group. It was quite interesting, the WhatsApp group. You start off with a WhatsApp group with clinicians, and of course you get football scores and what are you doing at the weekend happening on this thing, and that's good in the sense that it's improving matiness, but these things have to be policed. No football talk, and no personal details about any patients, and certainly no photographs of faces. But when well managed, the surgical consultation networks using WhatsApp were actually amazing, and district hospitals got usually a mean of two responses to a question, a surgical treatment question within the hour. We looked at the whole costs of having an ambulance system in a poor country, and then the pundits amongst us, and this was actually led by the team from Amsterdam, looked at group model building. If you increase capacity in a small district hospital, what else is affected? And incredible complex neural networks of what was involved in improving surgical systems. And on our website, we've got a bunch of little YouTubes of people talking for 60 seconds on various parts of the project. So a bit of an overview, and you haven't got the full results yet, but thank you, a big thank you to the entire team. And there's our website if you want to look at it. So that's Canter through project number 2, and project number 3, which has pretty much most of its time been subject to COVID restrictions, is our group working with the Ministry of Health in Zimbabwe to set up a joint public-private initiative hospital for children's orthopaedics. And there's an overview of the hospital taken from a drone. Now, how did this particular relationship start? Well, just over 5 years ago, a group from our Oxford University Global Surgical Group of orthopaedic surgeons from the NOC were invited over by the orthopaedic trainees in Zimbabwe to do a course on joint replacement. And we orthopaedic surgeons just love joint replacement, putting large chunks of metal into hips and knees. And the orthopaedic trainees in Zimbabwe, and actually the surrounding countries, work in systems where there isn't regular joint replacement, and we're very keen to have instruction on joint replacement. And here's one of my colleagues, Roger from the NOC, doing a knee replacement in sore bones, and Chris from the again from the NOC there, doing another knee replacement. While we were there in Zimbabwe, in Bulawayo, we saw a ruined old isolation and fever hospital owned by the Ministry of Health. It was disused. It had had a fire which had burnt every single piece of wood in the building and melted the glass and metalwork and destroyed the roof, and was actually just used as a public toilet by passers-by. And there's the team from Oxford with our wonderful hosts just standing in front of that building. And we were challenged in Zimbabwe and had long discussions with our hosts over the need in Zimbabwe for children's orthopaedics. There was some children's orthopaedics taking place by general orthopaedic surgeons, but no specialist children's orthopaedic surgeon, and certainly no specialist unit for children's orthopaedics. And so over the next 5 years, we had meetings with the Ministry of Health over the use of this building. The Ministry of Health said that we could have use of that building for free for the next 49 years. And if we could raise the capital to renovate it, then we could run it on a public-private initiative with the Ministry of Health. So we set to with local surveyors surveying the region. There's the big old building you saw in the first slide, and there were 2 wards either side as wings. We designed a theatre surgical block, which you can see on the left-hand side in the middle here, and I can tell you there's nothing better as a surgeon than designing your own theatres. You can think, well, how big do I want it? And in orthopaedic surgery, we want our theatres big, so that you can have 1 or 2 image intensifiers, and you don't have to climb over them to get round the theatre. You want the theatre coffee room to be 4 steps away from the operating theatre, so you can get your coffee quickly, unlike at the JR where you've got to use your card and go through about 16 fire doors. You want the toilets quite near, etc. So you can, it's great fun designing your own theatre and then thinking, where do we want the sun? Oh, in the morning, I actually quite like the sun coming up over the coffee rooms. Anyway, so then we designed the operating theatre, and the wonderful thing about Google Earth is that you can go back through Google Earth and see changes that Google's picked up. Well, there was our site where we just started the renovation. We took the damaged roofs off. We cleared the space for the operating theatre, dug the trenches for the walls of the operating theatre. When I say we, it wasn't actually me. I was watching this from the UK and doing regular visits to keep an eye. But we employed a local, 2 local architects and a local building team. There we are, just stripping the main building, the walls of the operating theatre coming up, a new roof on the old building, framework for the roof. There we are. We sent up a drone to keep an eye on our progress. Wonderful new roof, and the beauty of the old building starting to come back. And there we are, during the dry season, roof on the operating theatre. And there it is as it opened. And we managed to open the hospital during COVID in May of 2021. And the little sign of the Times is the little COVID testing centre here, where we did PCRs on all of our patients before operating. There's the before and after pictures. I'm not going to give you a tour of the hospital, but just show you one wall in the kids' ward of the picture of Noah's Ark, and a reminder: the day the hospital opened, before we had any patients in there, we employed all the staff and did staff training for several weeks before we opened the hospital. And the day the hospital opened, the first of the lockdowns started, and the government banned more than 7 people from being in a room. So no problem, while the sun's shining, everyone gets their chairs, and we did all the teaching and training in the car park outside. So there's the last look at the hospital. Thank you. And I'll hand over now to Grace.
Thank you, Chris. So just to finish, a little bit of an overview about the Oxford University Global Surgery Group. So we've just shown just a few of the projects that our team are involved in, but our aims are a group are firstly advocacy for global equity in surgery, obstetrics and anaesthesia, Second, to work with our partners and support them, those in low middle income country settings who are engaged in clinical, educational and research activities in global surgery. And third, to be a resource of advice and opportunities for those who want to get further involved. You can find out more about us on our website, who we are, publications, different projects, events, research, partnerships, and we have a mailing list as well. And you can find us on social media at Ox Global Surge. We meet regularly on Thursday mornings, just for a half hour to share project updates, both from our team and also from invited speakers. It's a friendly, informal setting. And when we are able to be in person, we're usually up in NDS for these updates and then for coffee afterwards in the George Pickering Centre, and anybody's welcome to join us. So that's it. Thank you very much. I think we've got some time for questions as well.